Dr. Kahlon?
Hi, everyone. Can you hear me?
Yes.
Okay, great. So I'll get started right away in the interest of time. I know we only have 60 minutes. So I'm going to be sharing with you first my disclosure that I have no financial relationships with any commercial entity producing healthcare-related products or services. And what we're going to be talking about today is going to be reviewing the model for improvement, how to create effective aim statements and key driver diagrams, and designing and implementing tests of changes, and understanding how to measure and spread the improvement once you're convinced it's really an improvement. So why do we why should people change, and why are we always asked to change? And this is a quote by Don Berwick: "If you always do what you have always done, you will always get what you have always got." And so systems are designed for a purpose, and that is what they will deliver. And in order to get different results, we must make changes. So changing systems and changing people. So why is it so hard? Change is threatening. It's always been done this way. Change is time consuming. Sometimes people feel, what's the point? It'll only disrupt the system. Change means testing out things in your own setting, which can be threatening to some people, and some people may never be happy with that. It's also neurological, and it's been shown that actually the ability to manage the emotional component of change is difficult for some people and easier for some people. So there is a scientific basis behind why we sometimes don't want to change. So how has it been done so far? So organizational change usually follows one of two routes. We either have a wholesale change, the current system seizes and the new system puts in place without being first tested, or there is a huge amount of information gathering, exercise, and endless speech with no change actually taking place. And so that's the trial and learning, which is basically an ideal segue for the trial and learning approach that the model for improvement, which I'm going to talk about, actually advocates for. So, so these are the principles of the model for improvement. Is it worth doing? You don't want to change for the sake of changing. You want to identify principles, change ideas. What has worked for someone? What might work for us? You want to measure progress, know what's happening. Is it actually making a difference? Test changes, start small, reduce the risk, and I'll talk more about that, why it's important. Implementing and sustaining the change, change in systems and routines, and developing skills and abilities to sustain that change that you're trying to implement. So I'm going to get into the model for improvement. I'm not sure how many on the call are familiar with the model for improvement, but it's a simple yet powerful tool for accelerating improvement. It was developed by the associates in process improvement who then contracted with the IHI to market this model. The model is not meant to replace or change models that organizations may already be doing. It's supposed to supplement what you may be already using and help you accelerate improvement. This model has been used very successfully by hundreds of healthcare organizations, many countries, to improve many types of different healthcare processes and outcomes. And it has basically two parts. The fundamental questions, which is the thinking part. What are we trying to accomplish? How will we know that a change is an improvement? And what changes can we make that will result in an improvements that we are seeking? And then we have the Plan, Do, Study Act, which is testing ideas before implementing changes, the doing part. So I'm going to get into each of the questions. So what are we trying to accomplish? What is our aim? What are our explicit aim statements? What are specific actions, stretch goals? And what are the characteristics of our SMART aims. So it's being specific, measurable, attainable, relevant, and time specific. So, why is this important? It is important because improvement requires setting aims, and an organization will not improve without a clear and firm intention to do so. So the first question is really to identify an aim. Teams of 10 answer this question by developing an aim statement. So you may want to develop a team that is really spending some time doing this work and really understanding what do they want to achieve. And it often identifies, an aim statement often identifies a specific action that will be taken to meet the aim, as well as the stretch goals. So it needs to be specific, it needs to be measurable, attainable, relevant, and time specific. So here's an example. A clinic will improve the care of HIV/AIDS patients by making changes in the following areas: self-management and adherence and support, decision support for clinicians, clinical information systems, delivery system design, community linkages, and leadership, focusing on education and prevention and early intervention. That's a lot. And our goals will include, and so here are some examples of potential aim statements. So 80% of patients with at least one visit every 3 months, 85% of our patients with documented medication, education, adherence counseling, 90% of applicable patients with PCP, MEC prophylaxis. So is this time specific? Well, not really. We don't know. We want to achieve an aim statement by agreeing on what we want to be achieving, and we want to write the aim statement down first clearly. We want to include numerical goals to clarify the expectations, extremely important. Set stretch goals, kind of push ourselves. We don't want to maintain the status quo, and we want to, at the same time, communicate immediately and clearly that what that need is going to be and what are we trying to achieve, and pushing ourselves a little bit. We want to avoid aim drift, and this actually happens quite a bit on projects, is people may think, oh, things are not working, let's start backing away from the aim. And, once an aim has been set, the team needs to be careful so that it does not back away from it or deliberately drift away from it unconsciously. So if you have set a goal, you want to constantly repeat the aim continuously at each meeting, whenever you start the meeting, and remind people what you're really there for. And the next tip is be prepared to refocus the aim, perhaps on working on the smallest part of the systems first. And this should not be confused with aim drift. And the reason is it's not backing away from a stretch goal, but it's consciously deciding to work on a smaller part of the system, which is often a good tactic. So your overall aim, maybe you want to reduce the turnaround time for patients by 50% by December 2013. But then the smaller components of that could be, the refocus would be, well, maybe we want to take X, Y, and Z clinics and achieve that goal. So making that very specific and with a smaller focus. So I'm going to talk a little bit about the PDSA. This was originally developed by Walter Schuhart and was known as the PDCA cycle, and then was modified by Edward Deming to PDSA to replace the check with study. And basically, it's all from the trial and learning approach that he wanted to look at it more from a study fashion. What can we learn about it before we can actually, start changing what we were trying to implement and test something new. So the P is the change that we want to be tested. So what's our plan? The D is the do, carry out the change, test or change. And study is data before and after the change and reflect on what we've learned. And this does not always have to be just data. It's actually the experience that people have had. And plan the next change cycle or full implementation. So what is a PDSA? It's a structured approach of making small incremental changes to systems, testing and identifying further changes before implementing anything on a broad scale. And that's really important to understand that this is a very, it's almost a safer approach to try things on a smaller scale before you go ahead and implement something. So like I say in the next bullet point, it's a common sense, easy to understand tool for bringing about change, and it also helps reduce anxiety to change, and uses the action-oriented learning methodology. So why should we test changes? We want to decide on several proposed changes that will lead to desired improvement. So the last thing you want is you go and implement a change in your clinic flow, and you realize that actually it's having damaging effects on your overall clinic operation as a whole. So you may want to test that on a smaller scale before you do that. And that typically is done very, very minimally on, one appointment, one patient, one physician, so something very small. Predict whether the proposed change will work in the actual environment of interest. You may want to also evaluate the costs, social impacts, side effects from the proposed change. And a lot of times, like I mentioned previously, it's hard to change, so it minimizes resistance and failure to implementation. So people will actually gradually start getting used to doing things differently because they're actually doing action-oriented learning, so they're seeing the results of what they're doing. So it's actually quite a useful method. So what do we mean by testing a change on a small scale? So you use volunteers or team members to do the tests, use smaller subpopulations, use one location, you conduct it for a short period of time, and here I give examples, trying out a new way to make appointments for one consultant or one clinic, trying out a new patient information sheet with a selected group of patients before introducing the change to all clinics or all patient groups. So what are the steps in the PDSA cycle? I'm actually going to go through each of these steps, but let me just go back to the slide. Is, like I mentioned, in the planning stage, we're setting the aim, we're setting our objective, we're asking the questions, why, what are our predictions, what do we think will happen, what's our plan to carry out the cycle, who, what, when, and where, and what's our plan for data collection, how will we, measure this. We'll carry out the plan, we'll document it, document the problems and unexpected observations, and then we'll begin the analysis of data. In the study, we complete the analysis of the data, we'll compare data to the predictions from step one and summarize what we've learned so far, and then we will actually act, that is, what changes are going to be made and how will we plan for the next cycle, what are we going to modify in the next cycle to test. So I'm going to walk you through an actual PDSA. So here's a real example adapted from the IHI literature. Is the aim here was to decrease surgical site infections by 30% within 4 months. And the PDSA cycle was structured around determining the feasibility and effect of asking the anesthesiologist to administer the first dose of prophylactic antibiotic within an hour of the first incision. So the plan was, the objective is to test a way to ensure that the first dose of the antibiotic is administered within 1 hour of incision time. And why were we saying this was important? That the anesthesiologist will be the best able to ensure that the first dose of antibiotics is administered within the 1 hour of incision time. So we developed a plan, who, what, when, and where. We will test this change on 4 patients next Tuesday. The charge nurse will notify the pharmacy which will deliver the antibiotics to the perioperative area before the patient arrives. Dr. Green will ask Dr. Smith, the anesthesiologist, to administer antibiotic within 1 hour of incision, and Dr. Smith will administer the first dose of the antibiotic and will document the administration time and incision time. So the second step is the do. So we're going to try it out on a small scale. So the day before the test, we discussed the plan with Dr. Smith, who agreed to do the small test. And the day of the test, we selected 4 patients from the operating schedule and notified the pharmacy. Dr. Smith administered the antibiotic in 3 of the 4 cases due to late arrival of 1 dose, and Dr. Smith did not record the incision times twice out of the 4 times due to intervening priorities. So study. So we have set time aside to analyze the data and learn from the study results. So we checked into why the single antibiotic dose arrived late and found that the patient's surgery was moved up due to an emergency case requiring a special room. So it raised the question, do we need a better communication system with the pharmacy? We also discovered that the reason Dr. Smith could not document the incision time twice was because he was working with the patient's airway and the anesthesia settings at that time and did not witness the actual incision. So someone else maybe potentially should be documenting this incision time. In the cases where both incision time and antibiotic dosage time were documented, we found that the antibiotic was administered within an hour of the incision time, verifying our prediction. So in the ACT phase, we tried to determine what modifications need to be made to our original plan. So the team decided that because it was difficult for the anesthesiologist to document incision time because of the other activities occurring at that time, another member of the surgical team would have to document the incision time. The team thought that the circulating nurse could document the incision time more easily than the anesthesiologist. And the plan for the next test was to ask the circulating nurse to document the time of incision. The anesthesiologist will continue to administer the antibiotic and document the time, and the team will work on a new method of communicating changes in the surgery schedule with pharmacy and test that communication plan by next week. So that was one PDSA cycle, and now you've planned for the next one, but then why don't we just stop on one? Because each test generates a lot of useful information, what worked, what did not work, and provides information on what we can do differently next time. And often in the process, new questions are raised. It also helps resolve the barriers in making the change work in the system to prepare for implementation, and like I've said previously, ensures buy-in and we can overcome resistance. So how should we effectively link? So we want to think ahead and test in over a wide range of conditions. We want to collect data, which is useful from each test to guide the next test. We want to keep it simple. We want to scale down the size, like I had mentioned previously, 1 patient moving on to 2 patients, so incrementally increasing it. We want to recruit volunteers or the early adopters, as a lot of people say, who are already thinking that they're excited about this, because if you start thinking of getting consensus initially, it's going to be a huge bottleneck. Just go for it. Get started. Don't overthink it, and just start testing the change. So repeated uses of PDSA cycle, and here's a schematic that shows you start with a bright idea, you test it out, you learn from it, you plan another test of change, and you're able to accumulate information, data, and knowledge, and eventually able to implement new systems and processes and plan for sustainment thereafter. So this actual example that I had shared with you, they actually moved on to they linked different cycles and were able to reduce surgical site infections. So, served like a useful tool for them. Can you test multiple changes at the same time? So teams can definitely test. So you could be testing, you're trying to implement a new form. Simultaneously, you could be testing maybe a new check-in process. So as long as all the changes are aimed at achieving the same ultimate goal, that's fine. So using several linked PDSA cycles allows the team to test more than one changes simultaneously. And this is important because if you start waiting to test each change separately, it's going to take you forever to implement something. So Here's an example. A team working on reducing the average extubation time for erective CABG patients worked on several changes at the same time, as well as each of the changes went through several linked PDSA cycles. So change one was to standardize pain management, and in order to be extubated early, patients must not be too heavily sedated. So the team began by revising the existing standards for postoperative pain management. Instead of using the traditional high dose of morphine, the team tested the use of smaller, more frequent doses. Patients' pain was managed adequately and were awake enough to be extubated safely. Similarly, in parallel, they were standardizing anesthesia management. The team tested having anesthesiologists use lower doses of sedatives to prevent patients from remaining heavily sedated long after the surgery was completed. Yet another change they were testing is establish a nurse and a respiratory therapist run rapid weaning and extubation protocols. The team also developed a set of criteria that patients needed to meet in order to be extubated safely, given the changes in anesthesia and pain management. And then similarly, to reduce the delays in obtaining arterial blood gas results, they did something simultaneously, and so on and so forth. So implementing and spreading changes. So after testing a change on a small scale, learning from each of the tests and refining the change through several PDSA cycles, the change is ready for implementation on a broader scale. So for example, from an entire pilot population, you might want to expand to an entire unit. So implementation is a permanent change. So that involves building the change into your organization. So some of the challenges are you can have effect on documentation, policies, hiring, compensation. So, any of those aspects of the organizational infrastructure that are not heavily engaged in the testing phase, that's sometimes a challenge. Also requires the use of PDSA cycle in each area that the change needs to be spread. So implementation needs to keep, planning for implementation, you need to keep that in mind. So here's an example. Testing a change, 3 nurses on different shifts use a new medication reconciliation and order form. Implementing a change would be all 13 nurses on the pilot unit begin using the new medication reconciliation and order form. Spreading a change of all 30 nurses on a pilot unit successfully implement a new medication reconciliation and order form, then spread would be replicating this change in all the nursing units in the organization and assisting the units in adopting or adapting the change. So, here's an example of the Scottish Primary Care Collaborative. It's one of the practices that use the PDSA model to improve, blood pressure. A percent of patients with diabetes who had a BP over a certain number. So they did, PDSAs to validate the diabetes register, PDSA to contact all patients who have not had a BP check in the last year, to improve shared diabetes information with secondary care. So these are all the different PDSA cycles along the way to achieve their goal ultimately. So in summary, Deming has constantly emphasized iterating towards an improved system, and hence PDSA should be repeatedly implemented in spirals of increasing knowledge of the system that converge on the ultimate goal of whatever that may be, and each cycle is closer to that goal than the previous. So here's an example of what a PDSA worksheet for testing change should look like. This is the IHI worksheet. You can obviously modify it to work for your hospital setting or work setting. So here you have the aim, your plan, really laying out what's the change going to be, who's the person responsible, when is it to be done, where it's to be done, and what's the plan, what are some of the tasks that need to be set up to test this change, who's responsible for that, when and where will be done, what is our prediction, what are the measures to determine if our prediction succeeds, The do piece, describe what has actually happened when you actually went out and tested, and then what is in the study phase. You're going to be measuring the results and comparing it to the predictions. And like I mentioned previously, you're going to, in the act phase, you're going to say, okay, what are the modifications we need to make, and how do we plan for the next cycle? So measurement for improvement. What is measurement for improvement? Why measure anything? Why should you measure? How do you collect your data? And how do you present and share your data? So I'm going to talk about this. So when you're measuring for improvement and you're measuring for research, it's actually, the purpose is very, very different. So the QI world tends to be very, very, we're working in a dynamic environment. We need to constantly understand what's going on, and we want to bring new knowledge into our daily practice. In research, it's a different goal altogether. It's to discover new knowledge. Tests, you have many sequential observable tests. It's iterative learning, and here you have one large blind test in the research world. You gather data that's just enough to learn and complete another cycle and learn about what you want to do for the next cycle. And here in research, you gather as much data as possible, and it's the just-in-case mentality. What if tomorrow in the future we're analyzing this data, we might have wanted to ask X, Y, and Z. So you collect whole lots of data just in case you miss something. And the duration is, in the improvement world, small tests of significant changes accelerate rate of improvement. So we do these rapid tests, and meanwhile in the research world, you can take long periods of time to obtain results. So you can see the rationale behind collecting data for research or improvement is very different. So why should we measure? It's obviously a critical part of testing and implementing change. It allows us to understand if the change has actually resulted in an improvement. Also helps us determine what's the further impact of the change, and it provides evidence for our improvements. So what should you measure? So obviously develop aims before your measures, design measures around aims, make measures easy to be collected by staff, and should not take longer than 1 week. So how will we know that a change is an improvement? We will measure the processes and our outcomes as well. So we need a family of measures. We need outcome measures, we need process measures, we need balancing measures. What are outcome measures? Measures are the measures of a customer or patient. So simple way I try to say this in the medical world is outcome measures are the result of what we actually do to patients. And process measures are things that we actually need to be doing in order to treat our patients. So those are things that are just part of our practice that we need to be doing. So in terms of outcome measures, whether changes are actually leading to improvement. So what we're doing, are we achieving the outcomes we desire? So for diabetic patients, our average hemoglobin A1C levels for a population of patients with diabetes, that's typically considered a marker of an outcome. In ICUs, the percent unadjusted mortality, and then adverse drug events per 1,000 doses. So process measures of the workings of the system, like I said, things we should be doing for our patients in order to treat them. So for diabetic patients, it's the percentage of patients whose hemoglobin A1C was measured twice in the past year, average daily clinician hours available for appointments, percent of patients with intentional rounding completed on schedule. In parallel, we need balancing measures, and why those are important is we could be making changes in one part of the system. We want to make sure that nothing new, no new problems are cropping up in other parts of the system. So for reducing time patients spend on ventilator after surgery, we want to make sure that reintubation rates are not increasing. And for reducing patients' length of stay in the hospital, making sure readmission rates are not increasing. So I'll give you some tips for measurement. So obviously you want to plot data over time. You want to track a few key measures over time. And it's really, really important because you're able to understand effectively how your performance has been over time. Typically, in the research world, we will do a very combined analysis over a period of time, but we may not look at data over time unless we specifically are trying to understand something from our research question. But typically, data is bundled up together. And using run or sure charts are simple and effective ways to determine that whether your changes are resulting in improvements. So what happens is when you do something over time, you're able to annotate your chart and able to understand based on certain rules if the improvements you're implementing are actually the changes you're implementing are resulting in improvements or not. So the perfect is the enemy of good, and this is often observed in academic medical centers that are very, very focused on research, very much focused on measurement has to be 101% accurate, and we have to absolutely get it right. Well, measurement is not the goal here, improvement is. And you just need enough data to understand whether your changes are leading to improvement in your system or not. Sampling is a good strategy, a simple and effective way to help a team understand how a system is performing, and it can save time and resources while accurately tracking performance. So you may want to work with your biostatisticians to see what may be a good sampling method and the minimal amount of cases that you'll need in order to understand things about your system. So you want to integrate measurement into the daily routine. Useful data are often easy to obtain without relying on information systems, and absolutely don't delay getting data. It's really, really important. If you're trying to test something today or tomorrow, you don't want to get data a week later. It's really not going to be very useful. It's not going to help in the iterative process of learning that you're trying to employ and test changes sequentially. You want to use both words and numbers, use qualitative and quantitative data. And so an example here would be ask the nursing staff on how adherence counseling is going or how to improve the no-show process. So the people who are a part of the process are really invaluable, and they're highly informative in understanding what the changes are actually resulting in. Very, very important to create a measurement plan. I always stress this in my day-to-day work. It's very important to be clear on what you were planning to measure and how you were measuring it, and documenting it, because often people will say when you share data with them after testing changes, oh, that's so not the case. We don't typically do this or that. Well, this is your evidence that this is what was agreed upon to measure, and then you won't have measurement creep, measurement scope creep, I should say, where measures conveniently keep changing if your process is not improving. So I think it's a good idea to create a measurement plan. So you may want to define a start point for your data that is relevant to the aim you're trying to achieve. You can collect data in very simple fashions, Excel spreadsheets, tick box sheets if you're observing the process manually, look at existing information, any patient and staff questionnaires. You want to build measurement as much into work, and you want right person to capture the right data at the right time, extremely important. And you want to define improvements in raw numbers as well as percent improvement. It gives you two different perspectives. You want to use newsletters, intranets, posters, etc., to really present and share your data with all the stakeholders in the process. So I'm going to talk a little briefly about run charts and control charts, because I know last year there was a session that was done in depth about these, but run charts are really useful. They are line graphs where measure is plotted over time, and often it is done with a median, and the reason for that is the middle value of those plotted is half above and half below the median. Changes made to a process are often marked on the graph, so it's annotated, so that they can be connected with the impact on the process. So what is a run, and how do we count a run? So one or more consecutive data points on the same side of median is considered a run. We don't include data points that fall on the median. We draw a circle around each run and count the number of circles you have drawn. That's the number of runs you'll get. Count the number of times the sequence of data points crosses the median and add 1. So here are the rules. So in order to observe if any change you're making is resulting in a process shift or resulting in a change or an improvement, so these are some rules. So you have a shift of 6 or more data points on either side of the median, 5 or more data points trending upwards or downwards, too many or too few runs is also another sign, and then an astronomical data point, that is an extremely high data point that you're able to clearly identify something special was going on there. Meanwhile, you have control or Schuer charts. They use the arithmetic mean as the center line. These tend to be more sensitive in nature than run charts. So if you have the capability of using control charts, it's always better to, you may want to be sure you have enough data points. Typically the rule is you may want to have 16 to 20 data points to get a meaningful interpretation out of a control chart. You can do run charts up to 12, as long as you have 12 data points available. And data points doesn't necessarily need to be months. It can be weeks. It can be days. It just depends on what you're trying to test and measure. The mean is actually calculated by taking all the values and dividing it by the number of values, which we commonly think of as an average. And because of the relative distances from the mean are taken into consideration, Schuer charts, like I mentioned previously, are more sensitive for detecting whether the observed variation is due to common or special cause variation. And I'll really quick say that special cause variation is something special going on in our system, which is not something we see in routine. Common cause variation is what is a part of the system. It's essentially the noise within the system. So a simple example would be you're coming to work every day, you use a specific route, and you have 5 to 10 minutes of deviation in time every day. So that's common cause variation. Special cause variation is when you would experience 45 minutes to an hour of delay to your routine travel time on your usual route. So think of it that way. So here is a chart that talks about the different types of data that you will encounter: classification data, count data, continuous data, or measurement data, also called that, and what type of control chart you should use. And this just gives you that example. And again, I won't get into this in detail because I know there was a separate session done on control charts. Here are the rules. So you have a single point beyond the control limits. Rule number 2, a shift of 8 or more consecutive points above or below the center line. Rule 3 is a trend of at least 6 consecutive points up or down. Rule 4, 2 out of the 3 consecutive points near the control limit or outer one-third, also referred to that. And at Rule 5 is at least 15 consecutive points are hugging the center line, the inner one-third. So if any of you use control chart software, a lot of them will come with different types of rules. I typically use the healthcare API rules, which are actually 6 different rules. So it just depends on what type of software you're using and what type of rules you're using. But typically, they are all trying to just identify the control the special causes in your control chart. So we're going to skip to the last part of this presentation, which is organizing your improvement project. And so I'm a big fan of driver diagrams, and they really help you to understand your system that you're working with. So typically, when I start a project, I will sit down and answer the questions for the model for improvement, develop an aim statement, and first thing I'll do is I'll start constructing a driver diagram. And why this is so useful, it provides a systematic way of laying out the aspects of the improvement project so that they can be discussed and agreed upon. And it also organizes your information on the proposed activities so the relationships between the aim of the improvement project and the changes to be tested and implemented are made pretty clear. And it helps complete the model for improvement framework. It allows you to link the first question what are we trying to accomplish, and the third, what changes can we make that will result in an improvement. By making the aim, the changes we will test and implement explicitly allow us to determine what measures we will need to track so that we can answer the model for improvements second question, how will we know that the change is an improvement? And I'll actually show you some examples in later slides. So driver diagram has 3 columns: the outcome, which is the established aim statement, typically on the left side, the primary drivers, which are a set of factors or improvement areas that we believe must be addressed to achieve the desired outcomes. So these are the things that are preventing us from getting us to our outcome. So these are really, really important. And they may be written as straightforward statements rather than numeric targets. Secondary drivers are specific areas that we will plan changes or interventions, and each of these will actually contribute to at least one primary driver. And these should be process changes, and we should have a great degree of belief to think that they will be impacting the outcome or the aim. So they should have an evidence base of sorts. So here's the schematic showing your primary outcome or your what is your aim on the left side, your primary drivers, and then your secondary drivers. Here's an example from the pediatric, it's the Pediatric Rheumatology Care and Outcomes Improvement Network based out of Cincinnati Children's Hospital. And the global aim here is to improve outcomes for children with JIA. And as you can see, they have a global aim, and then they have created smaller, more specific aims around different areas. And what are the key drivers, and what are the interventions that they're going to implement in order to address the key drivers that will ultimately impact the global aim. Here's another one that talks about billing for insertion of continuous epidural catheters. And similarly, you have your SMART aim, global aim on the left side, and your key drivers and your interventions on the right side. So with that said, that's all I have for today, and I'm happy to answer any questions. I wanted to leave enough time. Here are some references.
The conference has been unmuted.
Thank you, Prerna. This is Lynn again. Thank you, Prerna, very much. That was very helpful. I was particularly struck by your statement that measurement is not the goal, improvement is the goal. We so often get bogged down in the data collection that we forget where we're headed. So that was very helpful. I also like the idea of creating a measurement plan.
Right.
Sometimes people just jump right in and without planning. And I think it's always a balance of how much planning. You don't want to get stuck in analysis paralysis, but you do want to have a solid plan before you start running.
Right.
All the lines are now unmuted, so if you have any questions that you would like to ask Prerna, please just speak up. I do want to remind you before we end to remain in the conference session until the survey displays, and that way you can complete the evaluation form. So do we have any questions or comments?
Hi, I had a question. Wondering if there's a way to access the forms that you displayed that we could try and use here.
Sure. I think the session is being recorded, so you'll have, if you actually go to the IHI website and you Google measurement plan, and it'll bring it up.
Okay, thank you.
Yeah. The session is being recorded and will be posted on YouTube, and there will be a notice sent out and a link on the MAHQ website. But a lot of, as Prerna said, a lot of the forms that you've seen are part of the IHI model, and you can find samples on their website. Any other questions or comments? Prerna, I had a question. I was very intrigued by the driver diagram. That's something that I haven't used a lot of in my practice, and I think it could be really helpful in helping teams think about what is driving their issues. How do you approach that in a team setting? Do you do that in sort of a brainstorming activity?
Yes. So typically what I do is when we embark upon a project, we will spend the first few sessions on defining the aim statement.
Mm-hmm.
And once the aim statement is clear, we will spend the next few sessions on the driver diagram. And I think this is really important because it gets the whole team organized on what are the barriers from achieving this aim that we have set. And it helps us understand how do we target those barriers through our different improvement strategies we want to employ. And thereafter, we break into subgroups for each of those primary drivers if the interventions are different for each of those, and we go about and we work on our pieces, and we'll always reconvene our meetings, our overall project meetings, looking at the key driver diagram. So it's really useful, and it does come through active brainstorming. You have to obviously make sure that it's focused brainstorming. It's not something you want to endlessly do, but at least 2 or 3 sessions on key driver diagrams is really important.
Can I just follow up on that question, which is how does that differ from doing traditionally a fishbone diagram?
So in the fishbone diagram, you usually identify the causal factors for why something is not happening, but you don't really get the opportunity to identify what are the interventions you're putting in place. So that's the beauty of a key driver diagram. I often tell people that key driver diagram is a modified version of a fishbone, but it has the addition of the intervention piece or the improvement strategies you want to put in place. So it just lays it out, it gets you organized.
Great, thank you.
You're welcome. Anything else I can answer?
Any further questions for Prerna?
I actually have a question to the group. How many of you actually use control charts and run charts in your improvement projects?
I do.
Okay, so you have one person. And you use a software for that, or?
No, I use a sort of modified Excel format that was talked about at the last conference, but I've been using it for several years. It's not perfect, but it at least helps us display the data over time.
Is it UI macros?
Yeah.
Okay.
Yeah.
Right. Some of the other good tools that if people may want to start thinking about if you're looking at control charts is you have Chart Runner, which is Chart Runner Lean specifically. A really good tool. It lets you do a lot of fancy stuff in it, and it's very easy to use. So I would recommend that as a good tool to think about as well. So yeah. Anything else?
I have a question. Process mapping. In my practice, I usually do a process map before I go to the PDSA, so I am more focused on where I want to make some changes. What's your experience with that? I just didn't see you mention that in your presentation.
Right. So that was not the focus of my presentation today, but I absolutely agree. There is another presentation I do where I teach basic quality tools, and process maps are absolutely invaluable. So what we will do is we'll define our aim, and simultaneously when we're doing our key driver diagram, somebody from our team is going to be working with the stakeholders to create the process map. Because the process map is an eye-opener. There's nothing that you can't understand about your key drivers unless and until you have your process map in place. So I think
agree.
Yeah.
Thank you. Agree.
You're welcome.
Any other questions or comments for Prerna?
I have one quick question. Prerna, how do you help the group to see the difference between different kinds of customers, for example, internal customers and ultimate customers, such as the patient? And how do you help the group to see whether they should be going beyond their scope and incorporate feedback from all customers that touch a process?
So we always actually, when I'm working on a project, I always refocus everybody when the discussions start to go in different directions, that we're thinking about the patient. And the patient is most important. We need to be designing our process and getting input from all parties that are involved in this process. And increasingly, as you know, patients are being engaged more and more on different family advisory councils or through surveys. So, I think it's always good to revisit that what is the overall goal here, and constantly remind people, because people start focusing a lot on their area or their practice and not thinking globally. So I think it's important to remind the group constantly. And I'm a big believer that when you do a process map, you must include the people who live the process and send somebody with a fresh pair of eyes to do it, because then they're looking at things that people are not just taking for granted. And then once the key driver diagram is done, it's important to actually share that at a department meeting or a divisional meeting so that people understand what you have come up with as a group, but actually contribute towards it. A lot of times we realize that there were some key drivers, the primary drivers that we actually missed as a part of our brainstorming session. So it's important to get people's feedback.
Thank you. That's helpful.
You're welcome. Anything else I can answer?
Okay, then. Thank you, Prerna, very much. This was very interesting and very helpful.
Thank you. My pleasure.
Thank you. Please stand by.